Assalamu alaikum. My name is Urusa Khan and my roll number is BP1650244. I am from 4th Prof Morning and my group number is 24. Our topic is asthma and my subtopic is nocturnal asthma. Asthma is a long-term inflammatory disease of the airways of the lungs and it is characterized by variable and recurring symptoms, reversible airflow obstruction, and easily triggered bronchospasms. Symptoms include episodes of wheezing, coughing, chest tightness, and shortness of breath. Asthma is caused by a complex interaction between inflammatory cells and mediators. Mast cells, T lymphocytes, neutrophils, and epithelial cells are of central importance, and this inflammation also causes an increase in the existing bronchial hyperresponsiveness to a variety of stimuli. There are various types of asthma, for example, allergic asthma, non-allergic asthma, acute, chronic, nocturnal, seasonal, occupational asthma, exercise-induced asthma, adult onset asthma, and childhood asthma. My topic is nocturnal asthma, and it is a type of asthma that gets worse at night and is associated with increase in the symptoms and need for medications, increased airway responsiveness, and worsening of lung functions. And it is affecting a majority of asthmatics. It is associated with symptoms like chest tightness, shortness of breath, cough, and wheezing at night, and it can make the sleep impossible and leave the patient feeling tired and irritable during the day. These problems affect the overall quality of life and make it more difficult to control daytime asthma symptoms. Nocturnal asthma is very serious and it needs a proper asthma diagnosis and effective asthma treatment. The causes of nocturnal asthma: number one is increased mucus. Increased drainage from your sinuses can also trigger asthma in highly sensitive airways. Reclining position. Lying in a reclining position may also predispose you to nighttime asthma problems. Many factors may cause this, such as accumulation of secretions in the airways, increased blood volumes in the lungs, decreased lung volumes, and increased airway resistance. Air conditioning. Breathing colder air at night or sleeping in an air-conditioned bedroom may also cause loss of heat from the airways. Mechanisms of nocturnal asthma. The pathophysiology of nocturnal asthma is closely associated with chronobiology, that is, the science of biologic processes that have time-related rhythms. The 24-hour cycle is especially important in understanding the changes in pulmonary function that occur in sleeping asthmatics. Patients with nocturnal asthma symptoms may have greater nighttime activation of inflammatory cells and mediators, lower levels of epinephrine, and increased vagal tone. The patient may not take action during sleep to compensate for a lack of oxygen, and this can lead the asthmatic to undergo intermittent or acute hypoxia. As we can see in this chart, the airway resistance, vagal tone, histamine levels, mediator levels, cholinergic output, bronchial reactivity, and inflammatory cells are increased during the night in an asthmatic patient. And lung volumes, cortisol levels, epinephrine levels, mucociliary clearance, airway conductivity, temperature, activity of beta 2 receptors, oxygen saturation is decreased. And all of these factors lead to the symptoms of nocturnal asthma. Nocturnal asthma assessment. Nocturnal asthma is monitored by a combination of clinical history, subjective self-questionnaires, and spirometry. Number one is snoring. Snoring is correlated with the symptoms. Snoring may cause transfer of nasal mucus to the lower airway through upper airway vibration, and this may induce an asthmatic episode. Nocturnal wheeze. Wheezing is actually a high to low pitched continuous sound and is just to be of significant duration. And wheezing with unforced breathing is associated with the severity of airflow obstruction, and it is a good determinant for assessing asthma control. Measurement of nocturnal wheeze has been applied as a non-invasive technique to assess nocturnal asthma. The results provide objective home-based information that positively correlate with subjective symptoms and inversely correlated with the morning peak flow meter. Sleep quality. Many individuals with nocturnal asthma experience sleep disturbance because of their condition, and nocturnal asthma can cause fatigue and impaired performance the day after an asthma episode. So, if the patient is consistently feeling tired and unrested after a normal night's sleep, it may be possible that he is suffering from nocturnal asthma. Now, we will talk about the case study. A 41-year-old man presents to the clinic with a history of coughing and shortness of breath that awakens him at least 2 nights a week. Most mornings on awakening, he complains of chest tightness. He has a history of asthma since childhood and is currently managed with beclomethasone hydrofluoroalkane 160 mcg BID via a spacer and albuterol 90 mcg per puff, 2 puffs Q6R as per needed, and before exercise. His morning PEF is consistently in the yellow zone, usually at about 400 liters per minute, whereas the evening peak expiratory flow is consistently 550 to 600 liters per minute. What treatment should be recommended? So the chief complaint of the patient is coughing and shortness of breath that disturbs his sleep and chest tightness in the morning. And the patient is already a patient of asthma since childhood. His current medications are beclomethasone hydrofluoroalkane and albuterol. Objectives: the morning peak expiratory flow is 400 liters per minute and the evening peak expiratory flow is 550 to 600 liters per minute. Peak expiratory flow is actually the maximum expiratory flow a subject can produce, and it determines the degree of airway obstruction, and it is a tool for monitoring the patients with asthma. And here we can see that the patient's peak expiratory flow is decreased in the morning as compared to the evening. So the coughing and shortness of breath at night indicates that the patient is showing the symptoms of nocturnal asthma, which are troublesome in asthmatic patients. Chest tightness in the morning is a further clue to nocturnal asthma. Peak expiratory flow values show a diurnal variation, which indicates that the symptoms of asthma are more severe in the patient at night and the patient requires management so that he can continue with a normal undisturbed sleeping pattern. So as for the plan for this case study, the first drug therapy concern is to ensure that he is strictly adhering to his beclomethasone therapy and demonstrating excellent inhalation technique. And if his use of the medication is optimal, the reasonable approach would be to add LABA. LABA is actually long-acting beta agonist in which we can give salmeterol or formoterol, both of which have a 12-hour duration of action. Now, salmeterol is given with fluticasone, and fluticasone and salmeterol inhalation is a steroid and bronchodilator combination medicine, and it is used to prevent asthma attacks. The maximum dose for fluticasone will be 230 mcg and salmeterol is 31 mcg orally twice a day. And we have to make sure that the inhalations should be administered approximately 12 hours apart. The initial dose should be based on the patient's asthma severity. And if we talk about non-pharmacological management, the patient should be asked about avoiding or minimizing exposure to his asthma triggers. And that could be pets, dust, and mites. Notes. The initial approach to manage nocturnal symptoms or symptoms of asthma are ICS. ICS are inhaled corticosteroids and they are anti-inflammatory agents. And these are the medicines that are used to control and prevent symptoms of asthma and other lung conditions. And they help to reduce airway swelling, which causes most asthma symptoms and are often called controllers. So here the patient is already taking beclomethasone HFA, which is a inhaled corticosteroid. And we can see that the patient, although he is taking inhaled corticosteroids, but still his symptoms are not controlled. And a patient with asthma who is using an ICS at the recommended standard dose is already receiving 80 to 90% of the maximum obtainable benefit of the ICS. Therefore, if the patients require a step up of the treatment, they should have a LABA added to their regimen rather than increasing the ICS dose. So that is why I have suggested the addition of salmeterol with the combination of fluticasone, because the patient's symptoms are not well controlled. And before the advent of LABAs, we were using sustained release theophylline. Although it is helpful, but it has the potential to cause more adverse effects than inhaled agents, and it may interfere with sleep. And before a long-acting beta agonist is prescribed, adequate inhaled anti-inflammatory therapy should be ensured, and then the LABAs should be used. And bedtime doses of short-acting beta agonists do not have a sufficient duration of action to prevent early morning symptoms, as the patient was already taking albuterol, which is a short-acting beta agonist, and we can see that his nighttime symptoms are not controlled. So it means that they are not effective, and bedtime doses do not have a sufficient duration of action. That is why, along with ICS, we will give long-acting beta agonist. Thank you.